Ejaculating every day does not deplete testosterone, does not weaken your immune system long-term, and does not damage your prostate. Yet all three claims circulate constantly online. Today we're reviewing what daily ejaculation actually does to your body, hormonally, physically, and psychologically based on published research rather than internet myth. The most common claim is that daily ejaculation drains testosterone over time. Evidence level, this is not supported by current research. Testosterone does dip briefly within a small temporary range immediately following ejaculation, but returns to baseline within roughly an hour. No study has shown that daily frequency produces a lasting reduction in baseline testosterone in healthy men. Some smaller studies have examined short-term abstinence and found a modest, temporary increase in testosterone after several days without ejaculation, but this effect is small, inconsistent across individuals, and doesn't translate into any meaningfully different long-term hormonal baseline either way. Before continuing, a brief note: nothing in this video suggests a specific frequency is required or ideal for every man. Individual variation is normal. What follows addresses common claims, specifically, not a personalized recommendation, research examining ejaculation frequency and prostate health points in the opposite direction from what many assume. A large, frequently cited population study following men over multiple decades found that men reporting higher ejaculation frequency, generally 21 or more times monthly during certain periods of adulthood, had a measurably lower association with prostate cancer risk later in life compared to men reporting lower frequency. Evidence level, moderate, based on large observational data rather than randomized trials, meaning it shows association, not proven direct causation. Proposed mechanisms include clearance of prostatic fluid and reduced inflammation in prostate tissue, though these mechanisms remain incompletely confirmed in humans. This finding directly contradicts the common assumption that frequent ejaculation harms the prostate. Ejaculation triggers release of oxytocin and prolactin, both associated with measurable reductions in stress and improved mood in the period immediately following. This is a well-documented acute effect. Though it's short-lived rather than a lasting daily mood elevation, there's also a sleep connection worth noting. The prolactin release following ejaculation is associated with improved sleep onset for many men, connecting to broader themes of sleep quality covered elsewhere on this channel. This effect, again, is modest and short-term rather than a dramatic nightly intervention. Daily ejaculation itself is not associated with tissue damage or dysfunction in healthy men. However, mechanical irritation from friction, particularly without adequate lubrication, can cause minor soreness or chafing with very frequent activity, an issue related to technique rather than frequency itself. Men should be aware of a distinct condition, sometimes called post-orgasmic illness syndrome, a rare condition involving flu-like symptoms following ejaculation. This is uncommon but genuinely documented in medical literature, and persistent symptoms of this kind warrant medical evaluation rather than self-diagnosis from online searches. We're now roughly halfway through, and this is where the picture becomes more individualized. Everything discussed so far addresses population-level patterns. What follows examines how age, refractory period, and individual variation change what normal actually looks like. The refractory period, the recovery time before renewed arousal capacity, lengthens naturally with age, tied to hormonal shifts and nervous system changes rather than reflecting dysfunction. This means daily frequency may feel entirely different and require different recovery. For a man in his 30s compared to a man in his 60s, neither pattern is inherently abnormal. For the overwhelming majority of healthy men, there is no established clinical ceiling where daily frequency itself causes harm. Excessive frequency causing genuine physical irritation or significantly interfering with daily functioning is uncommon, and when present, often points toward a compulsive pattern worth discussing with a doctor or therapist, rather than frequency alone being the underlying issue. Before continuing, if you want a broader framework connecting hormonal health, sleep, and vitality after 40, Dr. Emily Carter's Guide, The Iron Age, the complete blueprint to reclaiming testosterone, strength, and vitality after 40 covers testosterone, strength, energy, and vitality across 9 focused chapters in a concise 14-page format. It's priced at $49.99 with the link provided with this video. It's educational, not a replacement for medical care, but it offers a clear framework for understanding how these systems connect. Clinically low or declining frequency is a more common concern than excessive frequency. A sudden significant drop, particularly alongside fatigue, low mood, or reduced interest broadly, is worth raising with a doctor. Since underlying causes ranging from low testosterone to depression to medication, side effects are common and frequently treatable once identified. The claim that frequent ejaculation weakens the immune system long-term traces back to a single small study showing a temporary immune marker change following abstinence, not ongoing frequent activity, and has been widely overstated and misrepresented online. The claim that it causes hair loss has no supporting evidence in human research. The claim that it depletes vital energy reflects folk belief rather than physiological data. Bringing this together, daily ejaculation does not meaningfully lower long-term testosterone, does not damage the prostate, and is not linked to lasting immune suppression in healthy men. Mechanical irritation from inadequate lubrication is a real but manageable and separate issue. A sudden change in frequency in either direction, accompanied by other symptoms, fatigue, mood change, pain, or unusual physical symptoms, warrants medical evaluation rather than assumption. Persistent distressing patterns that feel compulsive or that significantly interfere with daily life deserve a conversation with a doctor or therapist, not self-judgment. It's worth understanding why the testosterone depletion myth has proven so persistent, since it isn't a recent internet invention. Variations of this belief appear across multiple historical and cultural traditions. Some ancient Eastern medicine frameworks, certain historical Western physicians, and various folk traditions have all, at different points, framed ejaculation as a loss of some finite vital resource requiring conservation. This idea predates modern hormonal science by centuries, developing at a time when nobody could actually measure testosterone or understand endocrine function. Modern research simply hasn't found evidence supporting this older framework once actual hormonal measurement became possible. The myth persists partly because it's intuitive, loss framed as depletion feels logically consistent even without supporting data, and partly because it continues circulating through wellness content that doesn't distinguish between traditional belief and measured physiological evidence. Understanding this history helps explain why the claim feels so familiar and convincing to many men, despite the actual research not supporting it. A reasonable question worth addressing directly: does research on frequency, testosterone, and prostate health apply equally to masturbation and partnered sexual activity, or do these represent meaningfully different physiological events? The prostate research discussed earlier in this video generally measured overall ejaculation frequency without consistently distinguishing between partnered and solo activity in the underlying data. This means the population-level findings regarding prostate health apply broadly to ejaculation frequency itself, regardless of context. However, some research on oxytocin release specifically has found somewhat different intensity levels between partnered intimacy and solo activity, with partnered touch and connection generally producing a more pronounced oxytocin response tied to the additional social bonding component present during partnered contact that isn't present during solo activity. This doesn't mean solo activity lacks genuine physiological benefit, since the core hormonal and stress reduction effects discussed earlier still apply meaningfully. It means the magnitude of certain specific effects, particularly the social bonding component, may differ somewhat depending on context, worth understanding rather than assuming every effect discussed applies identically regardless of circumstance. It's worth addressing directly why normal frequency varies so considerably between individual men, since this variation itself is sometimes a source of unnecessary concern or comparison. Baseline libido is influenced by genetics, current testosterone levels, overall health, medication use, relationship status and satisfaction, stress levels, and simply individual variation that exists across any human trait, similar to how appetite or sleep needs vary meaningfully between otherwise healthy individuals. Comparing your own frequency against an average figure cited in research or against assumptions about what other men are doing generally provides less useful information than tracking whether your own pattern has changed meaningfully over time and whether that change is accompanied by other symptoms worth investigating. A stable, consistent pattern that feels normal to you, whether that's daily or considerably less frequent, isn't inherently a medical concern simply because it differs from a population average cited in a research study. Chronic stress and mental health directly influence both frequency and the subjective experience of sexual activity, worth understanding as part of this broader picture. Elevated cortisol from chronic stress can measurably reduce libido over time, meaning a change in frequency sometimes reflects an underlying stress or mental health pattern worth addressing directly, rather than representing an isolated physical concern in itself. Depression specifically is well documented in research to affect libido, sometimes reducing interest significantly, and certain antidepressant medications, particularly SSRIs, are independently documented to affect both libido and function as a known medication side effect. This creates a genuinely important clinical distinction worth understanding. A change in frequency accompanied by low mood, fatigue, or reduced interest broadly across previously enjoyed activities points toward investigating mood and stress as a potential underlying factor, rather than assuming the change itself is the primary problem requiring direct intervention. Beyond the prostate-specific research already discussed, it's worth addressing the broader cardiovascular connection, since erectile function itself, closely tied to ejaculation frequency for many men, serves as a genuinely useful window into overall vascular health. Since erections depend fundamentally on healthy blood vessel function, a man experiencing a gradual, unexplained decline in frequency tied to declining function specifically, rather than simply reduced interest, may be observing an early signal of broader cardiovascular changes worth investigating. This connects to a pattern discussed elsewhere on this channel. The small blood vessels involved in erectile function are often affected earlier in the progression of cardiovascular disease than larger vessels responsible for more commonly recognized symptoms like chest pain. This is precisely why a persistent, function-related change, rather than the frequency question in isolation, deserves genuine medical attention rather than assumption. Since this was mentioned briefly earlier in the video, it's worth expanding on what genuinely distinguishes a healthy, high-frequency pattern from a pattern worth discussing with a professional. The distinguishing factor, based on clinical frameworks used in this area, generally isn't frequency itself, but rather the presence of distress, compulsivity, or meaningful interference with daily responsibilities, work, relationships, or other valued activities. A man engaging in daily activity that he finds enjoyable, that doesn't interfere with his responsibilities or relationships, and that he doesn't experience as distressing or out of his control, doesn't meet clinical criteria for a concerning pattern regardless of frequency. Conversely, a man experiencing genuine distress, a sense of compulsion he can't control, or noticeable interference with work, relationships, or other priorities, regardless of the specific frequency involved, may benefit from discussing this with a therapist specializing in this area, since effective, non-judgmental support exists for this specific concern. This general topic remains one where accurate information is disproportionately hard to find compared to how common the underlying questions actually are. Most men have wondered about several of the claims addressed throughout this video at some point, yet cultural discomfort around the topic means many men never encounter a clear evidence-based answer, relying instead on whatever claims happen to circulate most widely online, regardless of whether those claims hold up under actual scrutiny. Providing this kind of direct evidence-based information isn't about encouraging any particular pattern or frequency. It's about replacing anxiety-inducing myth with accurate understanding so that decisions about this part of your life can be based on how you actually feel and function, rather than on outdated claims about depletion or damage that simply aren't supported by the evidence currently available. It's worth looking specifically at what large population surveys have found regarding typical frequency across different age groups, since this provides useful context for understanding individual variation discussed earlier in this video. Survey research examining sexual behavior across adult populations consistently finds frequency gradually declining, with age on average from a peak generally in the 20s and 30s through a gradual expected decline across subsequent decades. This average decline reflects several converging factors already discussed throughout this video: gradually declining testosterone, lengthening refractory periods, changes in relationship status and duration, and general health changes that accumulate over time. It's worth emphasizing that this is a population average, not a prescription for what any individual man should expect or target. Considerable variation exists at every age, and a man in his 60s with a frequency pattern matching the average for men in their 40s is not experiencing anything abnormal or concerning purely based on that comparison alone. What research consistently finds more clinically useful than comparing against a population average is tracking whether an individual's own pattern has shifted meaningfully relative to his own baseline, and whether that shift is accompanied by other symptoms. A gradual, modest decline over years, consistent with the broader population pattern, differs meaningfully from a sudden, significant drop occurring over weeks or a few months, the latter being considerably more likely to reflect an identifiable, addressable cause worth investigating. Some of the foundational research on human sexual behavior and frequency dates back several decades, including large-scale survey work conducted in the mid-20th century that first established some of the broad patterns still referenced in more recent research today. This historical research, while methodologically different from more modern studies in various ways, helped establish that considerable variation in frequency has always existed across the population, rather than being a recent phenomenon tied to modern lifestyle or technology changes. More recent research has built on this foundation using improved methodology, larger and more representative samples, and more sophisticated statistical approaches, generally confirming the broad pattern of significant individual variation alongside a gradual average decline with age. This continuity across decades of research, despite significant cultural and technological change over that same period, suggests these patterns reflect genuine underlying biology rather than being primarily driven by any specific modern cultural factor. Beyond the stress and mental health factors already discussed, general diet and health status meaningfully influence both frequency and function, worth understanding as part of this broader picture rather than treating frequency as an isolated variable disconnected from overall health. Cardiovascular health, already discussed in relation to erectile function, specifically connects directly to overall diet quality, given the well-established relationship between diet, blood vessel health, and blood flow throughout the body. Men managing elevated blood sugar or diabetes, conditions closely tied to dietary patterns over time, frequently experience related changes in function due to the nerve and blood vessel effects of poorly controlled blood sugar, discussed in other videos on this channel. Sleep quality, another recurring theme across this channel's content, directly affects testosterone production and overall energy, both of which influence libido and frequency. Physical activity level similarly connects to cardiovascular health, testosterone regulation, and general energy, meaning a broadly sedentary lifestyle can indirectly contribute to reduced frequency over time, separate from any of the more specific causes already discussed. This reinforces a theme relevant across nearly every topic covered on this channel. The body's systems are genuinely interconnected, and addressing broad health fundamentals, sleep, diet, movement, stress, tends to positively influence multiple areas simultaneously rather than existing as entirely separate, unrelated concerns. Building further on the antidepressant connection mentioned earlier, several other medication categories commonly prescribed to men over 40 and 50 carry documented effects on libido and function worth understanding, since a change coinciding with a new prescription is worth raising with the prescribing doctor, rather than assuming it reflects something else entirely. Blood pressure medications, particularly some beta blockers and diuretics, are documented in clinical literature to affect function in some men through mechanisms related to blood flow and nervous system effects already touched on elsewhere in this video series. Medications for enlarged prostate, specifically certain alpha blockers and 5-alpha reductase inhibitors, carry documented effects on ejaculation and libido as recognized side effects, worth discussing directly with a urologist if these effects are significant enough to affect quality of life. Certain medications for hair loss, working through similar hormonal pathways, carry similar documented considerations worth discussing with a prescribing doctor. None of this information is intended to discourage necessary medication use, since the underlying conditions being treated, high blood pressure, prostate enlargement, are themselves significant health concerns worth managing appropriately. It's intended to help men recognize when a change might be medication-related, which often opens the door to a straightforward conversation about alternative options within the same medication class, rather than assuming a change reflects a permanent, unchangeable reality. For men in long-term relationships specifically, it's worth acknowledging that frequency and interest are influenced by relationship dynamics themselves, separate from any of the physical or hormonal factors discussed throughout this video. Research on long-term relationships consistently finds that frequency naturally shifts with relationship duration, life circumstances, and relationship satisfaction, reflecting normal relational dynamics rather than purely individual physiological changes. This matters because a change in frequency within a partnered relationship isn't always best understood by focusing exclusively on one partner's individual physiology. Relationship stress, unresolved conflict, or simply the natural evolution of a long-term partnership can meaningfully influence this picture, sometimes more significantly than any single physical factor discussed elsewhere in this video. Couples experiencing a change worth understanding may benefit from examining the broader relationship context alongside, rather than instead of any relevant individual health factors. Bringing together several threads discussed throughout this video, it's worth offering a genuinely practical framework for what to actually do if you notice a significant, unexplained change in frequency in either direction, rather than leaving this purely theoretical. A reasonable starting point involves considering recent changes across several categories discussed throughout this video. Any new medication, recent significant stress or mood changes, changes in sleep quality, changes in relationship circumstances, and any other new physical symptoms, whether related to energy, weight, or general function. Identifying whether the change coincides with any of these factors often provides a useful starting point for understanding the likely cause, even before involving a doctor directly. If no clear explanation emerges from this kind of self-review, or if the change is accompanied by other concerning symptoms discussed throughout this video series, fatigue, mood changes, unexplained weight change, or changes in erectile function specifically, that combination genuinely warrants a conversation with a doctor, ideally including basic blood work checking testosterone, thyroid function, and blood sugar, which together address a substantial proportion of the identifiable, treatable causes behind this kind of change. This connects to a broader pattern discussed across multiple videos on this channel. Many men delay raising topics in this general category with their doctor, whether due to discomfort, assumption that nothing can be done, or simply not realizing that a symptom is medically relevant rather than an inevitable, unchangeable part of life. Doctors, particularly those specializing in urology, address questions and concerns in this category routinely as a normal, unremarkable part of clinical practice rather than an unusual or uncomfortable topic. Raising a concern directly, even briefly at the end of an otherwise unrelated appointment, considerably increases the likelihood of identifying and addressing an underlying treatable cause compared to continuing to manage an unexplained change silently based on assumption alone. Stepping back from the specific claims addressed throughout this video, it's worth reflecting briefly on why this general topic attracts so much confidently stated misinformation compared to many other areas of health. Part of the explanation likely involves the private, rarely discussed nature of the topic itself, creating an environment where claims can circulate widely and repeatedly without being challenged by the kind of open discussion and correction that occurs more readily around other health topics. This is precisely why videos grounded specifically in published research, clearly distinguishing between well-supported findings and unsupported claims, genuinely matter in this space. Men deserve accurate information about their own bodies, delivered without unnecessary alarm or unfounded promises, allowing decisions in this area of life to be based on evidence rather than persistent unexamined myth. Alcohol deserves specific mention here, since its effects on this topic are frequently misunderstood. In small amounts, alcohol can temporarily reduce inhibition, sometimes creating a short-term impression of increased interest. Physiologically, alcohol is a depressant that directly impairs blood flow regulation and nervous system signaling, meaning regular or heavier consumption is well documented to reduce function over time, separate from any effect on interest itself. Chronic, heavier alcohol use also independently lowers testosterone through effects on the liver's hormone metabolism and direct suppression of testosterone production pathways. This connects to a broader pattern discussed elsewhere on this channel regarding alcohol's cumulative effects on men's health generally. A man noticing a gradual change in function or frequency alongside a pattern of regular, heavier drinking has a genuinely identifiable, modifiable factor worth addressing directly, often producing noticeable improvement within weeks of meaningfully reducing intake. Smoking carries similarly well-documented direct relevance to this topic, given its established significant impact on blood vessel health throughout the body. Nicotine constricts blood vessels, and long-term smoking contributes directly to the same arterial changes discussed earlier regarding cardiovascular disease and erectile function specifically. Research consistently finds smokers experience measurably higher rates of erectile difficulty compared to non-smokers of the same age, an effect that improves, sometimes substantially, following smoking cessation, since blood vessel function shows genuine capacity to improve once the ongoing damage from smoking stops. This represents one of the more directly modifiable factors discussed throughout this entire video, and mentioning it here connects meaningfully to the broader vascular themes already established. Men noticing function-related changes who also smoke have a clear, well-supported starting point for improvement, independent of any of the other factors discussed. Body weight and metabolic health connect to this topic through multiple overlapping mechanisms already touched on individually throughout this video. Excess body fat, particularly around the abdomen, increases activity of an enzyme that converts testosterone into estrogen, directly lowering effective testosterone levels. Obesity is also independently linked to increased rates of diabetes and cardiovascular disease, both already discussed as relevant factors affecting function specifically. This creates a pattern worth understanding clearly. Weight, blood sugar, cardiovascular health, and testosterone are not separate, unrelated systems, but rather deeply interconnected factors that frequently influence each other simultaneously. A man addressing weight and metabolic health through sustainable, moderate changes rather than extreme measures often sees improvement across several of these interconnected areas together, rather than needing to address each factor in complete isolation. It's worth noting a nuance that sometimes gets missed in health content generally. Extremely aggressive caloric restriction or excessive exercise volume adopted suddenly in pursuit of rapid improvement can paradoxically suppress testosterone and reduce function further, at least temporarily, since the body interprets extreme caloric deficit or excessive physical stress as a signal to deprioritize reproductive hormone production in favor of more immediate survival functions. This is precisely why sustainable, moderate approaches to weight, diet, and exercise tend to outperform extreme rapid interventions when it comes to the hormonal and vascular systems discussed throughout this video. A gradual, consistent approach to improving diet quality, increasing physical activity, and addressing sleep and stress tends to produce more reliable, lasting improvement than an aggressive short-term intervention that the body may respond to as an additional stressor rather than a straightforward improvement. Bringing together everything discussed across this extended exploration of the topic, a clear pattern emerges. The specific myths addressed at the start of this video, testosterone depletion, prostate damage, immune suppression from ejaculation frequency itself, are not supported by current evidence. What does genuinely affect this area of health, sleep, stress, alcohol, smoking, weight, medication, and relationship dynamics connects to the same broader systems discussed consistently throughout this entire channel. This reinforces something worth remembering whenever encountering a specific, isolated health claim online. The body rarely responds to any single variable in complete isolation. Understanding the broader, interconnected picture, rather than fixating on one isolated factor like daily frequency itself, tends to produce both more accurate understanding and more effective action when a genuine concern does arise. So here's the bottom line. Daily ejaculation for most healthy men isn't harmful, and most of the specific claims circulating about testosterone, the prostate, and the immune system aren't supported by current evidence. 3 practical takeaways. Don't chase or avoid a specific frequency based on internet claims. Use adequate lubrication to prevent mechanical irritation, and treat a significant sudden change in either direction as information worth mentioning to a doctor. If this addressed something you'd wondered about but never had explained clearly, that's exactly why this video exists. The Iron Age Guide is linked with this video. Thanks for watching, and I'll see you in the next one.